Hi, this is Nurse Inga. You're watching Hematology for Pediatrics. First, let's start with some vocabulary. Hematopoiesis means blood cell formation, and that includes things like red blood cells, white blood cells, platelets, and lymphocytes. Hematopoiesis occurs within the bone marrow, and all of these cells come from a pluripotent stem cell, which is then triggered by hormones to create specific cells. Erythropoiesis, for example, is red blood cell formation, and the kidneys release erythropoietin, a hormone that triggers the stem cell to make red blood cells or erythrocytes. And this is regulated by kidney perfusion and oxygenation. So when the kidneys sense hypoxia, they trigger the bone marrow to create more blood cells. The term dyscrasia or blood dyscrasia refers to either abnormal lab values or abnormally formed cells. So there's something wrong with the blood work. Erythrocytes, or red blood cells, they particularly carry oxygen and help with clotting. Leukocytes are white blood cells. Their primary role is to fight infection. And thrombocytes are platelets, and they form platelet plugs and stop bleeding, so they are responsible for clot formation. The lymph system parallels the venous system. It filters the plasma that returns from the vasculature, destroying any pathogens that have been picked up in the interstitial spaces, and it stimulates antibody production. Lymphadenopathy is the enlargement of lymph nodes, and this signifies that there's infection, inflammation, or disease. Painful lymph nodes that are inflamed typically mean that there's some sort of an infection, versus enlarged lymph nodes that are rubbery and non-tender oftentimes indicate cancer or disease. The spleen is the largest of the lymph organs. Anemia is the inadequate cellular oxygen supply. It's a red blood cell problem. There's either a decreased number of red blood cells or impaired functioning of the red blood cells, so that oxygen is not carried in adequate supply to the tissues of the body. Typically, if there's a hemoglobin less than 8, this causes an increased cardiac output, so an increase in heart rate, as well as activation of the RAS and the sympathetic nervous system, which causes vasoconstriction and blood shunting away from the non-essential organs. Therefore, pallor, weakness, fatigue, dyspnea on exertion, tachypnea, tachycardia, all of those things are present when someone is experiencing anemia. And then destructive anemias will also have jaundice because red blood cells are being broken down very quickly and the bilirubin is being released into the bloodstream. Iron deficiency anemia is the most common childhood deficiency. Typically, it's related to diet, but it also can be related to bleeding. We see this usually during infancy from about 9 to 24 months, and then again in adolescence. Usually inadequate diet, excessive growth requirements, the inability to absorb iron, like from consuming a lot of cow's milk, or hemorrhage, or when young women get their periods and then they're not eating really well, all of those things can contribute. If untreated, it slowly progresses, and if left to become severe, it causes muscle breakdown and weakness, including the heart muscle, which can become eventually too weak to function. In severe chronic cases, growth retardation and cognitive dysfunction can occur as well. So treatment really is just supplementation. Oral is preferred. So ferrous sulfate is iron, and we give it orally 2 to 3 times a day, not with food. So you don't want to give it with calcium, you don't want to give it with milk. You want to give it either with vitamin C or in between meals because it's best absorbed with acid. And if you're going to give liquid iron, you can mix that in orange juice or something acidic with vitamin C, but you want to use a straw because it will stain the teeth. You see here some common signs and symptoms of iron deficiency anemia. So an elevated respiratory rate because there's poor oxygen carrying capacity. Koilonychias are a spoon shaping of the fingernails. And then angular cheilitis is kind of a chafing of the lips and the corners of the mouth. Atrophic glossitis is a kind of pink, smooth tongue. For mothers who are breastfeeding for the first 6 months is best. If babies are being bottle fed, they should use iron fortified formula throughout the first year. Cow's milk really has little to no iron in it at all, and so the more a child drinks cow's milk without other good iron sources in their diet, the more likely they are to develop iron deficiency anemia. You can teach the parents that when they do supplement with iron, that the stools will be a dark tarry green to almost brownish black looking, and that's normal. They also may become very thick and sticky, and sometimes they smell bad. In African and Mediterranean areas where malaria is common, there is a genetic mutation, which is called sickle cell trait, where there is a small amount of this hemoglobin S or sickled hemoglobin that actually protects you from malaria. When both parents have the sickle cell trait and the child then inherits 2 recessive genes, the child actually then has sickle cell disease or sickle cell anemia. So it's this autosomal recessive disease. And typically the symptoms don't appear until the end of the first year of life. But if the parents are concerned, they can get tested prior to birth or newborn screening with something called the Sickle Dex. So what happens in sickle cell anemia is there is a lot of these hemoglobin S molecules because with the trait, there's just a few of them, but once you have the disease, because of the double recessive, you tend to make a lot of these. And they don't carry oxygen like a normal hemoglobin does. They have this elongated kind of sickle shape that are very rigid. They don't make it through like tight corners very well. They tend to clump together and obstruct blood flow, which can cause ischemia or infarction and can permanently damage organ function. Really, the key to preventing this is adequate hydration and oxygenation. But when it does happen, liberal pain management and then, adding in the hydration and the oxygenation really is key to managing the patient who's having a problem with their sickle cell disease. You may notice kind of some of the classic signs of anemia, like the child may be pale, tire very easily, or have poor appetite. But you also might notice that they have failure to thrive, they get swelling at the fingers or toes, abdominal pain. So it's really important to kind of put all the pieces together, and if they have those risk factors, to test them for sickle cell disease. Acute exacerbations will vary in severity and frequency, and these are called sickle cell crises. And again, these are triggered by things like dehydration, infection, physical or emotional stress, or exposure to cold. Frequent bacterial infections can occur due to overall immunocompromise, and that leads to death actually in our younger children. So as soon as the parent recognizes respiratory or skin infections, they need to notify the physician and get seen right away. We also see strokes in 5 to 10% of our children with sickle cell disease, and they may have neurodevelopmental delay and even cognitive impairment. So there's three types of kind of crises. The first one is called vaso-occlusive crises, and this is the most common. It's extremely painful, where the blood gets kind of stuck and pools, the cells clump together in the microcirculation, which causes the ischemia and the infarction. You get fever, abdominal pain, stiff neck, muscle spasms, swollen joints, tissues get engorged, vomiting and hematuria are possible, especially if the kidneys are affected. And if the brain is affected or the central nervous system, there can be seizures, stroke, coma, or paralysis. Vaso-occlusive crisis can actually be fatal. There's splenic sequestration, so the spleen is responsible for a lot of blood flow. And if the occlusive crisis kind of occurs within the spleen, then the spleen obviously can like swell and rupture, and the patient can bleed to death. So blood kind of pools in the spleen, they become profoundly anemic, hypovolemic, they can go into shock, and this can be life-threatening, and death can occur within a few hours. And then there's aplastic crisis, and this is where there's a diminished production and increased destruction of red blood cells. And this is usually triggered by some sort of a viral infection or depletion of folic acid, and they become profoundly anemic and have really severe pallor. So aplastic means that they're not making any. Vaso-occlusive means that they've blocked off blood flow, and splenic sequestration is where the blood is getting kind of stuck in the spleen and getting destroyed way too quickly, as well as the spleen itself can become damaged. Another type of anemia is called thalassemia, and thalassemia is a genetic problem. It's a spontaneous mutation where the body can't make normal hemoglobin. And so the person has chronic anemia from this improper creation of hemoglobin, and the body recognizes that it's not made correctly, and so it rapidly destroys it. And therefore, there's a fairly severe progressive anemia that's evident by about 6 months of age, where the child chronically has pallor, hypoxia, poor appetite, fever, jaundice because of this rapid destruction, where the child actually becomes like this bronze color from a process that's called hemosiderosis. And hemosiderosis is the releasing of iron into the bloodstream and staining of the tissues or depositing in the tissues from either massive blood transfusions or from rapid destruction of red blood cells. The liver and the spleen become enlarged, the belly becomes distended, and the chest itself, they can have chest pressure from all of this swelling against the chest organs. There's massive enlargement in the bone marrow space where the blood cells are trying to be made, and then there's facial contour changes, and the child can go into heart failure. So as you see here in this picture, this is kind of a classic facial presentation of a child with thalassemia. The treatment really is frequent blood transfusions, and this again results in that hemosiderosis, or those iron deposits in the tissues. And because of that chronic elevated iron level within the body, there can be toxic damage done to the organs. Deferoxamine or desferal is an iron chelating agent that can be given to counteract the hemosiderosis. Splenectomy also may be used as a therapeutic measure to help kind of slow down the destruction of the red blood cells. And this is a chronic disease. It doesn't get any better. So really good emotional care and helping the child and the family cope is important as well. If you're giving a blood transfusion, the principles of blood transfusions apply to children as well as adults. So it's really important that you follow your protocols for identifying the patient and the blood. Infuse only through the appropriate blood filter and only with normal saline. You never add any medications to blood. Vital signs should be taken per protocol, and reactions, remember, generally occur within the first 15 minutes. Things like chills, itching, rash, fever, headache, and back pain would be a sign of a transfusion reaction. If you Notice a transfusion reaction, immediately stop the blood transfusion, disconnect it, and run a clean line of normal saline. Notify the physician or the provider and the blood bank immediately. And then you're going to send the blood bag back anyway for testing whether they have a transfusion reaction or not. One of the big things that we also worry about in kids is circulatory overload. So once you put extra cells into the bloodstream, they have a really large oncotic pulling pressure, and so all of the fluid from the interstitial and cellular spaces is going to get pulled into the intravascular space, and the child can rapidly experience circulatory fluid volume overload. So be on the lookout for things like, crackles, chest pain, shortness of breath, coughing, JVD, and be prepared to administer oxygen, medications like diuretics if needed to kind of counteract those signs and symptoms. So hemophilia is not an anemia, so now we've kind of moved on to the next group of problems. This is a group of hereditary bleeding disorders that results from clotting factor deficiencies. And it's sex-linked, specifically X-linked, and recessive. So females are carriers and males are affected. It varies in severity, and in about 1/3 of cases, it's a new mutation, so there's no family history. Symptoms usually don't occur until about 6 months of age, once the child really starts to get mobile and they're falling or get injured, and then you start to see bleeding. There's different types of hemophilia, but two of the big ones are hemophilia A, which is considered like kind of classic hemophilia, and that's about 80% of cases, and then hemophilia B, which is also sometimes referred to as Christmas disease, and that's only about 15% of cases. Things that you may notice in a child who has hemophilia would be things like ecchymosis, epistaxis, prolonged bleeding times, or just excessive bleeding from small injuries. Hemarthrosis is bleeding into the joint space of like the knee, the elbow, the ankle, the shoulder, and it leads to impaired mobility. And then they're very high risk for bleeding after procedures. So just minor traumas, tooth extractions, minor surgeries, subcutaneous and intramuscular injections can cause hemorrhaging into the tissues. And then any surgeries, especially like if they have the tonsils removed or adenoid, bleeding into the neck, the chest, and the mouth can compromise the airway. Increased risk of intracranial hemorrhage, or basically a hemorrhagic stroke from even minor head injuries, or increased blood pressure is also a concern. So the child who presents with like a severe headache or is acting strangely neurologically should always be evaluated for a bleed. The hemarthrosis particularly has a specific plan of care. So you want to immobilize the joint to stop it from moving so that the inflammation can go down, and then follow your regular RICE care. So rest it, that's part of immobilization, right? Ice it to decrease blood flow and swelling. Compression, like ACE wrap would be great, and then elevate it above the level of the heart. And all of these things will help to decrease the bleeding and the swelling into the joint. Pain management is important, but we're not going to give aspirin and we're not going to give NSAIDs. We're going to use either opiates or Tylenol. Range of motion is not performed until after the bleeding stops, but it's important to start it as soon as possible to prevent contractures. And then physical therapy is also very useful for these patients. The patient with hemophilia should avoid obesity to minimize stress on the joints and minimize the incidence of hemarthrosis. Medications that can be used to treat problems during hemophilia include desmopressin or DDAVP, and it can be given intranasally, IV, and there's actually an oral form as well. It increases factor VIII activity by 2 to 4 times, and it can stop bleeding. Amicar is an anti-fibrinolytic agent. It's also called tranexamic acid, or TXA, and it's really good for dental extractions and oral bleeding. Amicor stabilizes clots that already exist. It doesn't help make new clots, versus DDAVP helps make new clots. Then you can infuse or replace the clotting factors that are missing, or you can provide transfusions. Things that are important to consider would just be close supervision and safe home environment or school environment, avoiding the use of aspirins and usually most NSAIDs as well. Dental procedures can only be done in a very controlled situation. Shaving, when they get old enough, should be done with an electric razor. And if the child has a superficial injury with bleeding, you want to apply pressure for at least 15 minutes and apply ice at the same time to cause vasoconstriction. If significant bleeding occurs, transfuse the factor replacement. And you can talk to the parents, because it's difficult to not be overprotective. They're always going to be worried that their child's going to get hurt, but you need to balance protection with autonomy. The children need the ability to do what it is that they want to do. Focus on their strengths and what they can do, and allow children to participate in decision making about their care as much as possible. ITP, or idiopathic thrombocytopenic purpura, is petechiae caused by an excessive destruction of platelets due to an antiplatelet antibody that is activated after a viral infection. So this is kind of an acquired hemorrhagic autoimmune disorder triggered by a virus that then causes a clotting problem, lack of platelets, and petechiae. So it usually goes away on its own in about 4 to 6 months, but in the meantime, it's super important that you avoid anything that could cause bleeding. So no drugs like aspirin that can interfere with platelet function, no rectal temps or IM injections, anything that could cause, tears in mucous membranes or intramuscular hemorrhages. Assess for bleeding, the gums, the stool, any puncture sites. Limit activity during the acute phase. Steroids and IV gamma globulin can help decrease the autoimmune response. Splenectomy sometimes is necessary for this. And again, these guys are also at risk for intracranial hemorrhage because of the lack of platelets. We don't give platelets though, and so a lot of times you would think like, oh, their platelets are low, why not just give platelets? But if you think about the mechanism for this, they have antiplatelet antibodies, right? So if you gave them platelets, their body would just attack them and kill them. So they would just get destroyed. Okay, so let's talk about leukemia and lymphoma to kind of finish up here. So leukemia is the abundance of immature white blood cells that can't fight infection. So essentially you have leukocytosis, or lots of white blood cells with no white blood cell defense. And this overwhelms the stem cells in the bone marrow because they keep getting triggered to just make all of these white blood cells, and they're cranking them out. So they can't make adequate amounts of red blood cells and platelets. Therefore, the patient also has anemia due to decreased red blood cells, and they're at high risk for infection related to immature white blood cells, and they're at high risk for bleeding related to thrombocytopenia, so they don't make enough platelets. The spleen, the liver, and the lymph nodes show marked infiltration, so lots of white blood cells, just little immature white blood cells crammed in there, and those glands then get enlarged, and they can get fibrotic, and these little teeny tiny white blood cells can also invade the central nervous system. So leukemia is the most common form of childhood cancer. The peak onset is very young, between 2 and 6 years of age, and it's treated with chemotherapy, radiation, and even bone marrow transplant. We like to keep these kids in an outpatient setting whenever possible because their home environment is much more comfortable, but it's also safer if you just think about all of the germs that are in a hospital. And our main goal with these guys, because first of all, remember, they don't have white blood cells, but then we're also giving them chemotherapy and radiation, so we're increasing the risk of infection. So our goal really is just to decrease that risk. We want to put them in an environment and minimize any risk of infection. Adequate hydration minimizes kidney damage. Teach the family a lot about infection prevention. We don't do routine immunizations during immunosuppressive drugs because the body wouldn't create adequate defense. And then while they're receiving chemotherapy, we want to control nausea and vomiting so that they don't have weight loss. Oral care is super important. Kids get the same stomatitis and ulcers that adults get with chemotherapy and radiation. And help them verbalize their feelings, because this will help clear up any misconceptions and reduce feelings of isolation and loneliness. Lymphoma, as you can see here, are painless lumps, usually above the level of the clavicle. So in this one, it's along the neck. There are very few other manifestations. So for that reason alone, any painless lymph nodes that are enlarged above the area of the clavicle or above the level of the clavicle need to be further evaluated. In more advanced cases, there's also unexplained low-grade fevers, anorexia, unexplained weight loss, night sweats, general malaise, rash, and itching. Lymphoma can be categorized into two classes, so Hodgkin's and non-Hodgkin's. You can kind of remember the difference between them in terms of morphology is that Hodgkin's has Reed-Sternberg cells and non-Hodgkin's no Reed-Sternberg cells. So when they're looking at it, you have to biopsy the lymph node, basically, and then they look at it on a slide under a microscope with the staining, and it either has or does not have the Reed-Sternberg cells, and that's how we tell the difference between Hodgkin's and non-Hodgkin's. So with Hodgkin's, the lymph nodes are usually in the upper body, and they spread in a very predictable pattern, again, swollen, painless nodes. Weight loss, night sweats, persistent fever and malaise, cough, dyspnea, chest pain, recurrent infections, itching, and an enlarged spleen. In non-Hodgkin's, there's no Reed-Sternberg cells, but metastasis is common and the spread is very disorganized. It has the same signs and symptoms as Hodgkin's. So for both, you're going to biopsy the nodes, they're going to stage the progression. Chemo, radiation, and surgery are treatment options for both. But the prognosis is much better for Hodgkin's lymphoma than non-Hodgkin's lymphoma, specifically because of the spread and the metastases. For both, risk factors include things like HIV and immunosuppression. Those things increase the risk of developing lymphoma. Long-term prognosis at this point in time is excellent for Hodgkin's and fairly good for non-Hodgkin's lymphoma. So let's talk about chemotherapy and radiation, since we're going to use both of those treatments for a lot of these children. When you're providing care to a child who's receiving chemotherapy, they will have the same side effects as an adult. So they're going to have nausea, diarrhea, rash, hair loss, fever, decreased urine output, anemia, and bone marrow depression. It's going to put them at high risk for infection and malnutrition and stunted growth and infertility. It's really important to pre-medicate with something like Zofran for nausea prior to the chemotherapy sessions to really improve their ability to take food and water. Peripheral neuropathy and constipation from decreased nerve sensations to the bowel are both common. And the use of steroids to decrease inflammation can also mask signs of infection. It can cause fluid retention, induce personality changes, and have a Cushingoids type of reaction where they get the moon-shaped face, the elevated blood glucose, and some changes in kind of overall body composition. It's important that you educate about side effects and management of the side effects of chemotherapy for both the patient and the parents. For radiation, symptomatic relief of side effects of radiation and chemotherapy is probably the most important piece. Educate the patient and the family. Malaise is common. Fatigue is probably the most common side effect of radiation. The child is going to tire easily and may be very irritable. The skin is kind of tattooed in the area of the treatment, and that should not be wiped off or washed off. And in the direct area of the radiation therapy, the skin may become very sensitive. It doesn't get burned itself, but it is at high risk for sunburn, so should not be exposed to sunlight, and it should not be scrubbed because it's sensitive and it could be easily irritated with, like, harsh scrubbing or harsh chemicals. So you don't want to use like perfumed lotions or soaps or anything like that either. It's important to dispel the myth about radioactiveness. The child does not become radioactive during or after therapy, and that is a common misconception of children. They're not going to turn into a superhero, and if there's a spider in the room, they're not going to turn into Spider-Man. Sterility is often a side effect of treatment, and if the child is prepubescent at the time of radiation, secondary sexual characteristics and menstruation may be delayed. So thinking about these very sick children sometimes can feel a little overwhelming. And if you are working in pediatrics, especially with very sick kids, it's really important to meet your own need for support and renewal, and just thinking about what it is that you do to kind of keep your glass full. You can't care for other people if you're struggling to care for yourself. So thank you, as always, for watching. I hope you have a great day.